Dear participants, my name is Gab McDonough, and I'm the Educational Action Supporting Officer at ERN-EuroBloodNet, the European Reference Network for Rare Hematological Diseases. And it is my great pleasure to welcome you to ERN-EuroBloodNet Topic on Focus on Constitutional Thrombocytopenia, which is an accredited European online educational program targeting health professionals organized by the ERN-EuroBloodNet and in partnership with the CRPP, the French Reference Center for Inherited Platelet Disorders, and the Filière MHEMO, the French Constitutional Bleeding Disorders Network. The program consists of a cycle of webinars focused on constitutional thrombocytopenia, developed in collaboration with three experts, Professor Marie-Christine Alessi and Dr. Paul Saultier from Publique-Hôpitaux de Marseille, and Dr. Mathieu Fiore from CHU Bordeaux, who is also present in the audience today. As mentioned, this program is accredited. There'll be a short questionnaire at the very end. But before we start, let me share some home rules. Please note that the session is recorded and will be uploaded in the EBN e-learning environment. If you do not wish to appear, please turn off your camera and change your name on the platform. Also, please be kindly informed that your microphone is muted. If you have any questions about the presentation, please write them in the chat and they will be addressed during the Q&A session at the end of the webinar. I'll read those out loud, and then the experts will have the chance to answer those questions. Today's webinar is on constitutional thrombocytopenia and the management of pregnancy. The speakers are Dr. Remi Favier and Dr. Agnes Rigouzzo. Dr. Remi Favier is a medical doctor specialized in pediatric hematology, in particular pathologies of hemostasis, coagulation, and inherited platelet disorders. He worked in the Department of Hematology at the Armand-Trousseau Children's Hospital from 1979. In 2005, with Dr. Paquita and Dr. Alan Norden, he founded the French Reference Center for Inherited Platelet Disorders. He collaborates with Dr. Rigouzzo on the different clinical problems induced by the management of pregnant women with inherited and functional platelet disorders. Last but not least, Dr. Agnes Rigouzzo is an anesthesiology intensive care specialist at Armand-Trousseau Mother and Children University Hospital, Paris, France, and oversees the obstetrics and gynecology anesthesia unit at the hospital. Dr. Rigouzzo has published on anesthesia, intensive care topics within pediatrics, obstetrics, gynecology, including studies on early detection and treatment of coagulopathy and PPH, management of constitutional thrombocytopenia and pregnancy, different anesthetic regimes, and treatment of pre-eclampsia. He is a member of France's National Expert Committee on Maternal Mortality, the CNEMM. And with that, I pass the floor to you, and thank you very much for both of your presence, and we look forward to your presentation. Thank you.
Thank you, Gavin. We would like to thank the organizer for inviting us and giving us the opportunity to share our experience with our European colleague. The main objective of this presentation will be to summarize the most frequent inherited thrombocytopenia encountered in the obstetric population, the diagnosis and specific aspect of the management of inherited thrombocytopenia during pregnancy, and management of inherited thrombocytopenia during delivery and the postpartum period. As you know, pregnancy in women with inherited thrombocytopenia is a major matter of concern, as both mothers and the newborn are potentially at risk of bleeding. Numerous case reports and one reference and European study have been published in the literature. This presentation summarizes the common feature in the management of pregnancy for the most frequently seen inherited thrombocytopenia, the specificity of pregnancy management for women with dysfunctional platelet defect, such as Glanzmann thrombocytopenia, where Bernard-Soulier syndrome B allelic will not be detailed. To define a thrombocytopenia threshold, we need into account the physiological change of pregnancy, particularly in the second half. A 10% drop in platelet level is observed during normal pregnancy as illustrated in this figure taken from Bolen's work. Based on all of this data, most guidelines define thrombocytopenia as 120 giga by liter from the second trimester of pregnancy. In two prospective cohorts, Bolen and Salgno, the median platelet count at the end of a normal pregnancy showed a lower limit of 116 to 123 giga by liter. Approximately 10% of women with otherwise uncomplicated pregnancy have gestational thrombocytopenia with a platelet count under 115 giga by liter at the time of delivery, and 1% of a platelet count under 100 giga by liter without other etiologies. Review of the literature on inherited thrombocytopenia in pregnancy are rare and can be summarized as for only one of which take into account all the inherited thrombocytopenia encountered in the obstetric population. The possibility of inherited thrombocytopenia should be considered, as mentioned in the international Norris retrospective study, based on recent diagnosis of certainty. Its prevalence has probably been underestimated, particularly when it is only mild symptomatic. Inherited thrombocytopenia accounts for 1% of all thrombocytopenia. They may be present as early as the first trimester of pregnancy and may be moderate or severe. They may or may not be associated with dysfunctional platelet defect. They may be confused with gestational thrombocytopenia or immune thrombocytopenia since they are permanent and asymptomatic and should be considered in the absence of response to treatment. The most common are myosin 9 related disease and Bernard-Soulier syndrome. In a second paper, published in 2021, myosin 9 related disease is the most frequent form of inherited thrombocytopenia, and these women are at risk for immune thrombocytopenia misdiagnosis. In women with myosin 9 related disease, the heavy menstrual burden remains unknown. An increased postpartum hemorrhage risk is evident. Prophylactic platelet transfusion has been commonly used as prophylactic treatment. Rare cases of cerebral hemorrhage have been described in fetus. Their affected mother had greatly reduced platelet count. This individual risk assessment, taking into account the patient bleeding history, bleeding score, platelet count, and obstetric risk factor, had already been proposed by Hussein et al. In a previous review on May-Glynn anomaly, the old name of myosin 9 related disease and pregnancy, involving a larger number of patients. In this systematic review, the incidence of PPH in patients with a May-Glynn anomaly was estimated to be between 5 and 8%, which is not very different from the general population. But the estimated blood loss at delivery was slightly above the physical threshold of 500 milliliters. Therefore, an individual and multidisciplinary approach is most often proposed with case-by-case indication of rare prophylactic transfusion of HLA-compatible platelet, adaptation of the PPH management algorithm with early platelet transfusion in case of PPH, desmopressin and acid tranexamic was administered before placenta delivery. The risk of PPH is considerably higher in this fourth paper about Bernard-Soulier syndrome with a review of the literature. PPH was seen in more than half of delivery, and late PPH was seen more frequently than early PPH. Late PPH, up to 6 weeks after delivery, was more common in women with vaginal birth. Therefore, pregnant women with Bernard-Soulier syndrome should be managed by a multidisciplinary team in a tertiary unit experienced in the management of these patients with rapid access to blood product and platelet. In this study, 2/3 of the patients delivered by cesarean section. Platelet transfusion prophylaxis was used in over 40% of patients and when administered more frequently in case of cesarean delivery. Therefore, the risk of alloimmunization against HLA and or GP1B95 is a major concern, and women should be monitored for the development of antibody anti-HLA and anti-GP1B in order to give HLA-compatible platelets and identify fetus at risk of alloimmune thrombocytopenia. The safest mode of delivery for fetus at risk of alloimmune thrombocytopenia is not known, but instrumental delivery should be avoided. In summary, concerning inherited thrombocytopenia and postpartum hemorrhage, we can distinguish two groups. The first group is with a high risk of severe postpartum hemorrhage, like gray platelet syndrome, biallelic Bernard-Soulier syndrome. Appropriate experience delivery center is necessary. The second group with the moderate thrombocytopenia not associated with thrombocytopathia, like Meiglin, Ankyrin 26, monoallelic Bernard-Soulier syndrome, individual risk assessment, and important variability of risk bleeding is noticed. A multidisciplinary protocol is also necessary. If postpartum hemorrhage, adaptation of classic postpartum management algorithm with early platelet transfusion is necessary. And this is in this group that the interest of thrombopoietin receptor agonist may be discussed, keeping in mind the benefit-risk balance case per case also. We know also that the different thrombocytopenia have a bleeding risk different, and we can distinguish the group of thrombocytopenia with moderate to severe bleeding, like Bernard-Soulier syndrome, gray platelet syndrome, but also phelaminopathia ou cytosterolemia. And the second group is all the others with minor risk bleeding. Then, in summary, for the diagnosis of inherited thrombocytopenia during pregnancy, two possibilities are present. The most frequent, the platelet pathology, is known and has been investigated before pregnancy. In this group, we find severe inherited thrombocytopenia associated with severe functional platelet defect. And the second possibilities, the inherited thrombocytopenia is discovered during the pregnancy. In this group, we find thrombocytopenia with absence or with a moderate platelet functional defect, often detected in asymptomatic woman by a blood cell count, and this woman have few previous surgical obstetrical procedure. How to make the diagnosis then? The outset of the thrombocytopenia during the pregnancy is important for the diagnosis of etiology. In the first half of pregnancy, immunological and constitutional thrombocytopenia predominate, especially in case of severe thrombocytopenia under 50 giga/liter. In the second trimester, gestational thrombocytopenia appears, which differs from immunological thrombocytopenia, in that it is less severe with platelet levels most often above 100 giga/liter. In the third trimester, cause specific to pregnancy dominate with mild gestational thrombocytopenia and thrombocytopenia due to preeclampsia complication. For all patients concerned, the most common etiology remains gestational thrombocytopenia, which account for 80% of cases. However, it is a diagnosis of exclusion after other causes of thrombocytopenia have been ruled out. Inherited thrombocytopenia should be considered, especially in case of early thrombocytopenia or thrombocytopenia prior to pregnancy. Which biological test would be useful for the diagnosis? The platelet count should be checked to exclude an underestimated rate, and a smear should be performed, which may suggest abnormality of platelet morphology or extra platelet, and also presence of hemolysis with schizocyte. From 20 weeks of pregnancy, the priority is to rule out preeclampsia and its complication. Thrombocytopenia may be the first sign of severe preeclampsia or early HELP syndrome. Once the complication of preeclampsia has been ruled out, the following tests should be performed: an autoimmune evaluation to detect immunological thrombocytopenia or antiphospholipid syndrome, a viral assessment to look for infectious disease, and in the event of a positive bleeding score or suspicion of hereditary thrombocytopenia, an assessment of platelet function should be carried out and will be combined and will be associated with dosage of von Willebrand factor in order to exclude Willebrand 2b. In summary, we keep in mind also that clinical data may be present besides the biological test. This is in favor of inherited thrombocytopenia. There are abnormal clinical features discovered at the first trimester of pregnancy, family history of thrombocytopenia or hematological malignancy, patient bleeding history, recurrent anemia unexplained, thrombopenia detected as soon as childhood, misdiagnosis as immune thrombocytopenia suspected in case of no response to classical therapeutics. The second part of this talk will be conducted by Dr. Rigouzzo.
So, once the diagnosis has been made or is already known, the main goals of the survey during the first trimesters will be based on the severity of the thrombocytopenia and the bleeding symptomatology. Two situations. If the thrombocytopenia is severe or associated with abnormal bleeding score, the survey requires a multidisciplinary team in a reference center, including obstetrician, hematologist, anesthesiologist, pediatricians, and transfusion medicine specialists. Second situation, if the thrombocytopenia is neither severe nor associated with bleeding diathesis, during the first 2 trimesters, the obstetrical survey may be possible out of the hospital, but always in collaboration with the hematologist. Clinical monitoring during the first 2 trimesters will include the detection of abnormal bleeding with the help of a bleeding score. Any history of PPH has to be taken into consideration in the peripartum management protocol, given the high risk of recurrence. The obstetrical survey will be the same as for normal pregnancy, except for women with antiplatelet immunization or history of other adverse pregnancy outcomes, which may require more frequent fetal ultrasounds. Avoidance of treatments interfering with platelet function, like non-steroidal anti-inflammatory drugs, but they are very rarely prescribed during pregnancy. From a biological perspective, in cases of suspected inherited thrombocytopenia, and of course after ruling out obstetrical complications, all experts recommend regular biological monitoring, a monthly platelet count during the first and second trimesters, and more often, more frequent counts after 32 weeks of pregnancy, or in case of a rapid drop in platelet levels, to once a week or every 2 weeks. The screening of HLA or specific antiplatelet antibodies will be combined every month. The recommended objectives are if the patient is asymptomatic, to maintain the level above 30 giga per liter, the level of platelet count above 30 giga per liter during pregnancy. For delivery, there is no increased risk of bleeding, whatever the mode of delivery, if platelet count is above 50 giga per liter. And for obstetrical neuraxial analgesia or anesthesia, the platelet count must be above 70 giga per liter and platelet function normal. In all cases from 28 weeks of pregnancy, the follow-up will take place in the reference hospital that provides easy access to blood products, including platelets and hemostatic therapies, intensive care unit for adults and children, hemostasis specialist and specialized laboratory, and available pelvic arterial embolization team. In summary, up to 36 weeks of pregnancy in an asymptomatic patient with no risk of hemorrhage or premature delivery, there is no need to consider treatment if platelet count remains above 30 giga per liter. At the contrary, in case of platelet count below 30 giga per liter and or obstetrical bleeding risk and or premature delivery risk, the introduction of an active treatment must be discussed case by case by a multidisciplinary team. This multidisciplinary team will discuss the risks of PPH, the optimal management strategy according to the mode of delivery, but the choice of the mode of delivery will depend only on obstetrical conditions. For every patient, a written protocol for peripartum management must be established and available during all the third trimester of pregnancy. There are unfortunately limited data in the literature to guide medical teams in the estimation of and prevention of the postpartum hemorrhage risk. Only the Norris study published in 2014 concerning PPH risk and found an increased risk of PPH and even a more pronounced increase of PPH requiring blood transfusion in the population of inherited thrombocytopenia. This study identified potentially useful parameters to predict the risk of PPH. First, the degree of thrombocytopenia below 44 giga per liter before pregnancy and or below 50 giga per liter at delivery. And secondly, an history of severe bleeding tendency, especially during previous surgeries. Altogether, these results indicate that bleeding risk at delivery is increased in population with inherited thrombocytopenia. So, if needed, which treatments can be used during pregnancy and the peripartum period? First, tranexamic acid can be used if necessary during second and third trimesters of pregnancy. Regarding the first trimester, due to lack of data to ensure the absence of teratogenicity, tranexamic acid may be used only in situations where therapeutic abstention would be harmful for the pregnant women. If need of platelet transfusions, HLA-matched platelets will be the best choice, if available, to prevent maternal platelet immunization. Intravenous immunoglobulins may be indicated in case of maternal platelet immunization and risk of fetal thrombocytopenia. For recombinant activated factor VII, there are no data on its use out of Glanzmann and biallelic Bernard-Saultier syndrome. And regarding thrombopoietin receptor agonists, there is no approval for its use during pregnancy by any regulators, but up to date, a total of 45 pregnant women requiring a second-line treatment in a context of immune thrombocytopenia have been published with favorable maternal safety profile and no adverse events for mother or children. In the context of inherited thrombocytopenia, few case reports have been published yet. Indications were always decided on the case-by-case basis after careful assessment of benefit-risk balance. So, for now, thrombopoietin receptor agonists should not be routinely used in pregnancy and should be avoided in the first trimester until further evidence are collected. But in practice, when an indication has been decided after assessment of the benefit-risk balance, patient consent, and more often and mostly in situations where there is a marked risk of bleeding, the biological effect is obtained after 2 or 3 weeks of treatment. The duration of treatment is usually 2 or 3 weeks during the last month. The response rate is around 75%. In this context, postpartum thromboprophylaxis is possible, and the breastfeeding is possible after 5 days after the end of the treatment. As illustration of a potential indication of thrombopoietin receptor agonist in the context of myosin 9 related disease, here is a clinical case published by our team in 2018. For this patient, the inherited thrombocytopenia was diagnosed during infancy, and her platelet count was 55 giga per liter before pregnancy, with a normal platelet functions. During her first pregnancy, platelet count was 26 giga per liter at the end of the pregnancy, and then she experienced an induced labor because of preeclampsia, followed by C-section under general anesthesia because of the severe thrombocytopenia, and complicated by PPH with blood transfusion. So, therefore, for a second pregnancy, because of an increased risk of PPH and a previous anaphylactic reaction after platelet transfusion, she was considered eligible for a short oral treatment by thrombopoietin receptor agonist after 36 weeks of pregnancy for a duration of 3 weeks. We used here L-Thrombopag. As you can see in the right figure, platelet count increased to above 50 giga per liter after 12 days of treatment and reached a peak of 179 giga per liter at day 19. Because of breech presentation, a cesarean delivery was performed at day 27 of the treatment under spinal anesthesia without requiring transfusion and with normal blood losses. She had a healthy baby affected by the Meiglen disease and who presented no biological or clinical complication after 1 year clinical survey. For management of delivery in the inherited thrombocytopenia patient, the choice of the mode of the delivery will be based on the usual obstetrical criteria. Neuraxial analgesia or anesthesia is possible in the absence of platelet function disorders, and if the platelet count is greater than 70 giga per liter for epidural analgesia and above 50 giga per liter for spinal anesthesia. A particular situation can be highlighted if the platelet function profile is comparable to an aspirin-like profile. In this situation, neuraxial anesthesia may be discussed, as it is approved now for women taking aspirin during pregnancy. Platelet have to be available for a potential HLA matched platelet transfusion, and its main indication are severe thrombopenia below 50 giga per liter, prophylactic transfusion if serious platelet disorders, a rapid administration in case of early or primary or secondary PPH. The blood losses will be closely monitored, and prophylactic uterotonics will be administered based on the usual criteria. In the postpartum period, the non-steroid anti-inflammatory drugs, which are frequently part of postpartum analgesia protocols, are contraindicated. HLA-matched platelet transfusion have to be available, still available for early transfusion in case of secondary PPH. Postpartum thromboprophylaxis may be considered based on the usual obstetrical indication if platelet count is above 50 giga per liter. There is no specific recommendations for postpartum tranexamic acid administration in the context of inherited thrombocytopenia, but its administration may be discussed in case of thrombopathy, case by case. Neonatal platelet count will be monitored since the delivery, since the birth, to detect severe thrombocytopenia and the transmission of the maternal pathology. And the maternal survey will be extended to 6 weeks after delivery. So I let Remi Favier the conclusion. Hello.
In conclusion, diagnosis of inherited thrombocytopenia during pregnancy is probably underestimated. A correct diagnosis before conception is essential for appropriate management of pregnancy and delivery. Necessity to plan type of anesthesia, mode of delivery, prepartum therapeutic management in the last trimester by a multidisciplinary team. Severe inherited thrombocytopenia or inherited with functional platelet defect must be planned in specialized center at the beginning of the pregnancy. Antenatal follow-up is not the same in the woman at risk or with allo immunization. A survey of the postpartum period and the platelet count in neonate is necessary.
Thank you very much for your attention.
Great, thank you very much for your excellent and clear presentation. As mentioned earlier, this is a wonderful time to put your questions in the chat. Just having two incredible experts here with us. One of the questions that's come in already from one of our coordinators, Mathieu Fiore, Doctor. Thanks for this excellent talk. Do you have any experience regarding pregnant women with anti-platelet antibodies that pass through the placenta and induce fetal neonatal thrombocytopenia, for example, in BBSS?
We have no experience because in your center, Glanzmann thrombasthenia and severe Bernard-Soulier syndrome are not followed by your team.
Yeah, we work in a mother and children hospital without intensive care unit for adults. So with Remi, we used to follow women with inherited thrombocytopenia with mild or moderate bleeding symptomatology. For severe symptomatology like Bernard-Soulier, Bialelic, or Glanzmann, we propose the follow-up to be taken to take place in an adult hospital. But here in Trousseau, we look at, in another context. It's a specialized center for platelet immunizations. So we have a little bit this experience, and we used to deliver women with thrombopenic babies because of maternal platelet immunization, but not in the context of
Inherited.
inherited thrombocytopenia.
Right, thank you so much. There's another question in the chat. Thank you for your talk. Why do you recommend TXA only after placental delivery? We usually recommend it once there is active labor or 1 hour before a cesarean section. Thank you.
Because we propose it because the benefit has not been demonstrated if we compare the preventive, the prophylactic administration in between the birth and the delivery, like we proposed, and even for C-section, it can be done. It is usually administered in between the birth, after the cordon, je ne sais plus comment on dit,
Cord? Good.
the cord, yes. When the cord is sectioned, and the delivery. In my knowledge, there is no study at all in the context of inherited thrombocytopenia and prophylactic tranexamic acid. And in the largest context of obstetrics, there is benefit demonstrated. There is no prophylactic benefit which has been demonstrated, or maybe for very, very subgroups patients. It is well demonstrated as therapeutic, but not as prophylactic. So it's really an empiric indication.
Right. Thank you very much for the question, and thank you for the answer. Just a real quick reminder, this is part of a 15 webinar series. So I'd like to put the link, as there's a couple webinars left in this ongoing series coordinated by our 3 coordinators and in collaboration with EuroBloodNet. Also, once again, this is an excellent opportunity to ask our fellow experts if you have additional questions. Right now, you can put them into the chat. We have another comment. Thank you for your great presentation. And as a general reminder, I just want to mention the upcoming webinar on November 6th with Professor Barbara Zeiger on inherited thrombocytopenia and inherited thrombocytopenia, clinical cases, which is part 2 of a series. Is there any more questions from the audience, perhaps relating to the subject or any of the cases discussed? Now is an excellent opportunity to put them into the chat. Or feel free to activate your microphone to ask directly. And on that note, if there's no additional questions, I would like to thank you, a special thanks for both of our presenters today. Thank you very much for your very clear presentations and for your time and your expertise. Without the experts like yourself, this webinar series wouldn't be possible. So thank you very much. We're very grateful. And on behalf of the coordinators in EuroBloodNet, I wish you all a wonderful evening. So thank you. Many comments coming in to say thanks. So thank you once again. And have a great evening, everyone. Bye-bye.
Bye-bye.
Thank you.